In this video, we will focus on Mulligan concept. Now, it's not usual for me to add the history or the background of the concept, but I thought for Mulligan it would be necessary to understand the key points of the concept. So, Mulligan attended seminars based on Dr. James Cyriac's approach to orthopedic medicine, which included spinal manipulation, high velocity thrust, and passive joint mobilization techniques. If you haven't seen what Cyriac's technique is, you can refer to my previous video. He eventually expanded his knowledge in manual therapy by traveling to Helsinki to attend a Kaltenborn peripheral joint mobilization. Mulligan had his first MWM success, which ultimately changed his whole approach to manual therapy. So then you can see here he was inspired by Cyriac's, Kaltenborn, and also Metlin, I haven't mentioned here, to create his own technique of manual therapy. You might ask what MWM is. Movement with mobilization is the concurrent application of sustained accessory mobilization applied by a therapist and an active physiological movement to end range applied by the patient. Basically, it is passive movement by therapist and active movement by the patient. Overpressure or stretching is then applied at the end when pain is not the barrier to enhance treatment. The concept of MWM of extremities and sustained natural apophyseal glides SNAGS or SNAGS of spine was first coined by Brian Mulligan. The techniques by Mulligan that we are going to focus on are movement with mobilization or MWM, natural apophyseal glides or NAGS, sustained natural apophyseal glides or SNAGS, spinal mobilizations with limb movement SMWLM, and pain release phenomena PRPs. Before moving forward, few basics should be cleared. For concave convex rule, you may refer to my previous video. For now, we will be focusing on positional faults and treatment plane. Positional faults are a form of hypothesis. They can be thought of as any bony incongruence following injury or strain resulting in movement restriction and or pain. They are not readily palpable or visible on X-ray, but when a correctional mobilization is done, pain-free function is regained. Next, we are looking at the treatment plane. Basically, it's the answer to the question how to find the right direction of the glide. The glide should be applied parallel to the treatment plane, which is a line drawn across the concave joint surface. Basically, if you could slide a paper within the joint surface to divide the joint into half, that would make the treatment plane. You can see the diagram. The treatment plane will vary from person to person and may change as a result of bone remodeling following trauma or disease such as osteoarthritis. The treatment plane will also vary according to the patient's starting position. For example, in the extended knee, the treatment plane is horizontal in standing but almost vertical in supine. Particular to SNAGS or MWM in the spine, the gliding direction is always in the plane of the facet joint. This diagram explains the previous line, which said on standing the treatment plane is horizontal, on supine line the treatment plane is vertical. Here is the summary of treatment plane presented in a diagram. Let us look at the effects Mulligan techniques have on the body. Effects related to positional faults. Positional faults are first of all corrected. That means bone alignment is changed. Pain is reduced. Range of motion or ROM is increased. Following with biomechanical effects. Break adhesions, blockage removed from circulation, increase proprioceptive feedback, intervertebral disc fragment shifts, open the lock joints, reduce annular distortions, nerve decompression, and straighten the spine. Next, we have neurophysiological effect. Activates the pain gate theory, modulate peripheral nociceptors, cause relaxation of muscles, produce alterations in sympathetic and motor system, corrects abnormal reflexes. All these effects lead to what? Improved CSIM. CSIM is the task that the patient has difficulty completing, usually due to pain or joint stiffness, and this task is mostly a movement or a muscle contraction performed to the onset of pain or to the end of available ROM or maximum muscle contraction. CSIM is client specific impaired measure. Moving on to the procedure, the passive accessory force usually exerts a translatory or rotatory glide at the joint and as such must be applied close to the joint line to avoid undesirable movements. It may be applied manually with the therapist's or patient's hands via treatment belt or even with sports tape on the skin. The direction of the accessory movement that is used is the one that effects the greatest improvement in the CSIM. While applying MWMS as an assessment, the therapist should look for PILL response to use the same as a treatment. P for pain-free, I for instant result, and LL for long-lasting response. So if your Mulligan therapy is causing more pain to the patient and not giving instant cure and is not long-lasting, then you should not advocate that technique. The second principle is CROCS. C for contraindications, and this we will be looking in the upcoming slides. R for repetitions, only 3 reps on the day 1. O for overpressure, C for communications, K for knowledge of treatment plane and pathologies, S for sustained mobilization throughout the movement. So the steps are, when you are assessing or prescribing the treatment, use the PILL or CROCS principle. Identify CSIM that should be reproducible. Quantify CSIM through physical examination and rating scales. Decide the amount of MWM. During execution or treatment, position the patient's affected extremity and therapist. Application of accessory glide by the therapist must be pain-free. Consequent active movement by the patient and application of overpressure component only if pain-free. Following treatment, immediate restoration of pain-free range of motion is expected. If not, then self-treatment or application of strapping tape is considered or suggested that the therapist has not found the correct treatment plane or grade of mobilization or spinal segment, or the technique is not indicated in this procedure. The equipments that are used are Mulligan belt, plinth or bed, Mulligan pads and pillows. Here we have the image of Mulligan belt. In the next video, we will describe different techniques in the Mulligan concept that we saw earlier: MWMs, SNAGs, NAGs, pain release phenomena, etc.